Good evening. So first of all, I'd like to thank Dr. Ilham Yusri for giving me the opportunity to be here with you today. And our talk is about the CBC. So the outlines of our talk is how can the CBC be a window to different diseases? Then we will apply this to practical cases. Abnormal blood cell counts or abnormal blood cell morphology may reflect a primary hematological problem, but not only that, it may reflect an underlying non-hematological condition, or it may be the result of therapeutic interventions. We all know the importance of the CBC, but let me remind you that before holding the paper of the CBC in your hand, first of all, you need to KYP, know your patient. So all hematological results need to be interpreted in the context of thorough history and physical examination. And this is called the rule of thumb. We diagnose a patient, not a CBC. So interpretation of the CBC cannot be without the data from history, full history, age, sex, clinical history, family history, travel history, drug history. Every single word in the history is of extreme importance. And then the physical examination. So let's put together a very simple algorithm for how to go through the CBC. Number one, you need to look at the counts of the three lineages, the RBCs, the white blood cells, the platelets all together. Then we will look at every single lineage by its own, RBCs, then white blood cells, then the platelets. So the first step you need to do is to look at the counts of the three lineages, the white blood cells, the red cells, and the platelets, and to detect whether there is increase in the numbers or decrease in the numbers. And what is important, you need to know whether there is mono abnormality or this abnormality in bi-lineages or in tri-lineages. Number two, you need to look at the RBCs indices. And let me highlight something which is very important. You need to look at two things, the numerical value and then the morphological changes. The first number you have in the RBCs indices is the RBCs count, which is analogous to the white blood cell count. And it is the concentration of the RBCs per microliter whole blood. Let me stop here and ask you a question. Is this the most important number you need to look at in the RBCs indices? The answer is no, because we are not minded with how many RBCs are there. We are minded with how much hemoglobin these RBCs carry and then how much oxygen they can deliver to the tissues. But we do need to look at this number and detect whether it is normal or there is erythrocytosis or there is anemia. So the more important number that you clinicians need to look at is the hemoglobin, which is the concentration of hemoglobin in the whole blood. But here, let me remind you of something of extreme importance. You need to get back to the reference range according to age and sex, because especially in the pediatric groups, there is great variations according to the age. The next number we have is the hematocrit, which is the packed cell volume. What does this number mean? When I take the test tube from the patient and I put it in the centrifuge, this is what happens. It will be separated. The fraction of the blood volume that is made up of intact RBCs will be separated at the bottom of the tube and expressed as percentage. This is the hematocrit. So when this number is decreased, it refers that there is anemia, and when it is increased, it refers that there is polycythemia. The next number we have is the MCV, which is the mean corpuscular volume. And it measures the average size of the red blood cells. This number becomes of significant importance in categorizing anemias. For example, anemia caused by iron deficiency will lead to a decrease in this number, and anemia caused by vitamin B12 and folate deficiency will lead to increase in this number. The next red blood cell index that we need to look at is the MCH, which is the mean corpuscular hemoglobin, and it measures hemoglobin concentration within a single red blood cell. This number is actually what is responsible for the color of the red blood cells in the peripheral blood smear. The red color of the blood, the red color of the RBCs comes from the oxygenated hemoglobin they carry. So the more oxygenated hemoglobin in the red blood cells, the more red they will look like. So this number, when is decreased, will lead to hypochromia, and when it is increased, will lead to hyperchromia. The next number we have is the MCHC, which is the mean cell hemoglobin concentration, which is the average concentration of hemoglobin in a given volume of blood. So we all know that one of the important classifications of anemia depends on these numbers, the MCV and the MCH, when there is macrocytic anemia or microcytic anemia or normocytic anemia. I will not go into the details, you all know it, but it is important. The last number we have in the red blood cell indices is the red cell distribution width, and it is an indication of the variation in the red blood cell size. As this number decreases, this means that there is less variation in the size of the red blood cells. And when this number is increased, this means that there is more variation in the size of the red blood cells. It is non-specific, but it is important to look at this number. And now I'd like my dear Dr. Sally to tell you the RBC's morphological changes in the peripheral blood.
Thank you, everyone, and the organizing committee for inviting me. I'm Dr. Saleh Fishawi from National Cancer Institute. As Dr. Rania said, the CBC is a window for the diagnosis of many diseases. When we see a CBC, we should concentrate on two things, the numerical values, and that's the counts that are there, and the morphology. Any physician should always pay attention to these two abnormalities. For the RBCs, morphological abnormalities, we have so many things. When you see a target cell, a teardrop cell, ovelocyte, elliptocyte, or a sickle cell or fragmented cell, this should trigger to you. You have to go further for more investigations. Red cell inclusion bodies like basophilic stippling, Howell-Jolly body, this will give you an indication of what to do further within to ask more investigations for your patients. I will hand off to Dr. Rania because she's responsible for the count and I'm responsible for the morphology.
So yes, when there are morphological changes, you need to dig deeper and don't take it lightly. So we are done with the RBCs indices. Let's get to the white blood cells. Again, I will remind you all, you need to look at the numerical value and you need to look at the morphological changes. We have two numerical values to look at, which is the total leukocytic count and the differential count. As for the differential count, you have two numbers, the percentage and the absolute. And let me ask you a question, which is more important? The absolute is more important, so you need to know it. And as for the morphological changes, Dr. Sally?
For the white blood cells, it's a whole different issue. Morphological changes are so many, and they are more frequently encountered than the morphological abnormalities in the red blood cells, and they are more serious. So whenever you see a cell that shouldn't be in the peripheral blood and it comes in the peripheral blood, and this is represented by a morphological abnormality like a blast cell, a monoblast, a promyelocyte, a granular blast. This can trigger some serious problems, hematological disorders. Whenever you see toxic granulations, cytoplasmic vacuolations, or hypersegmented neutrophils, Shinya-Higashi anomalies, all these represent serious problems that need further investigations within the white blood cell morphological changes.
Okay, so the last lineage we have and we need to look at is the platelets count. Again, we will look at the numerical value, we will look at the morphological changes. So when we have thrombocytopenia, we need to think of three things that may happen. It may be due to decreased production, or due to increased destruction, or due to increased sequestration in the spleen. As for if the number is increased, there is thrombocytosis, you need to know if this is a primary increase or it's a reactionary to another situation, which is chronic bleeding or inflammation or whatever. We have an important number in the platelets, which is the MPV, the mean platelet volume, as there are disorders with small platelets and other disorders with giant platelets and other disorders with normal sized platelets. And you will not diagnose these disorders without this number, which is the MPV. As for the morphological changes,
platelet morphological changes are a bit scarce, but you can find tiny platelets, giant bizarre platelets, large platelets, dendritic platelets, hypogranular platelets. Even the simple as aggregate of platelets would give you a clue of what's going on in the coagulation of the coagulation state of your patients.
So again, whatever morphological change you have, you need to dig deeper. Let's now apply this to practical cases. Our first case, we have an infant male, has 4 months, was hospitalized for accentuated pallor of skin and mucosa. And as I said, we really need to go through the history thoroughly. So the family history. During the pregnancy, the mother was diagnosed with mixed iron deficiency anemia and vitamin B12 and folic acid deficiency because she was on a strict vegetarian diet. On the clinical examination, the general state of this infant, he had poor appetite, the skin tone, he had pallor and mild jaundice, and he had hypotony of the muscle tone. Let's look together at the CBC. I will remind you with our algorithm, we will look at the 3 lineages. As the TLC, it is normal. We look at the hemoglobin, it is dramatically decreased. It is 4.9, and the MCV is 101. As for the platelets, there is moderate thrombocytopenia. Now we looked at the numerical values. Let's have a look on the morphological changes this infant had. So we detected that there is bicytopenia, marked anemia, and moderate thrombocytopenia. The RBCs shows macrocytosis, anisocytosis, and poikilocytosis, and there was occasional hypersegmented neutrophils were encountered. I'd love to invite Dr. Ilham to know how she will think about this case.
Thank you, Dr. Rania. So know your patient. our patient acutely ill with bad family history لأن الماما كانت عندها nutritional problem، وعنده بصوا بقى في السي بي سي بايسيتوبينيا وماكروسيتوزس وانايسوسيتوزس وبيكيلوسيتوزس occasional hypersegmented neutropenia. الحالة دي أول ما بنقول بما إن know your patient والسي بي سي دي window to diagnose the disease، أول differential diagnosis هقولها في الحالة دي إن الطفل ده ممكن يكون عنده B12 and folate deficiency نظرا للباد nutritional history in the family، والماما كانت vegan. مش كانت vegan ولا vegetarian؟ vegetarian or vegan الاثنين very liable ل B12 deficiency. فأول ما هتجيلي ده CBC is a window to think this case may be B12 or folate deficiency، فهطلب further investigation، وده اللي بنقول إن CBC بيguide us for further investigation. عشان كده نقراه meticulously after knowing our patient. عايزين نطلب investigation تانية يا دكتورة رانيا. Yeah, I want to ask for B12 and folate level, methylmalonic serum and or plasma level, and homocysteine total homocysteine level. ولو طلعوا واطيين يبقى الدياجنوز الصح هي B12 or folate deficiency. However, لو طلعوا normal I will ask for bone marrow. يا ترى ليه هنask for bone marrow يا دكتور محمود؟ في الحالة لو طلع البي 12 والفوليت نورمال. and this is what we want to tell. الموضوع لازم يتقري كويس والتحاليل تبقى يعني sequential، مش نكتب لستة تحاليل وش وظهر. احنا know our patient، نطلب تحليل ونفهمه، نطلب الباكج اللي بعدها ونفهمها، وبعدين نجو further. هو لو طلع نورمال هنطلب ليه بون مارو يا دكتور محمود؟
Assalamu alaikum. First of all, this case is very interesting. The patient is actually, despite having macrocytosis, but still we are in hurry to diagnose him because he's an infant, he's having bicytopenia, and I'm having in the background that patients can have a very aggressive form of leukemias, which is infantile leukemias. So I need to exclude leukemias, doing a bone marrow, or at least to do flow cytometric studies on the peripheral blood to exclude. That's a must because acute form will not wait a lot.
Should we ask for bone marrow before knowing the B12 and folate level? No.
From hematological point of view.
Yeah, no, don't do that. يعني الحالة مش بتاعت bone marrow.
Then the answer is no, okay. But I will ask for bone marrow.
لا, don't ask. لو البي 12 والفوليت ليفل والميثايل مالونيك والهوموسيستاين ليفل كانوا فعلا impaired, this is diagnostic. So treat and follow your patient. If they were normal, go for bone marrow. And طبعا my worry هتبقى added to the worry of Dr. محمود إن الكيس ده طبعا we should be very worried about this case. فمحتاجة close watchable eye لو سمحتم. Thank you.
So let's go to case number 2. We have a 7-year-old boy with who gives a 7-day history of brief febrile illness with nausea, vomiting, and diarrhea. Over the past 24 hours, he was noted to have developed purpuric spots on his limbs and to have become anemic and ill-appearing child. Let's have a look on his CBC. We will look at the 3 lineages. TLC was 23, and as for the RBCs, the hemoglobin was 7, and the MCV is normal. As for the platelet count, there was marked thrombocytopenia. We looked at the numerical values. Let's have a look on the morphological changes. There was bicytopenia, anemia, thrombocytopenia. There is moderate leukocytosis, and the RBC's morphological changes here is very important. There is many schistocytes and many RBC's fragments, burr cells, anisocytosis, and poikilocytosis. there was absolute neutrophilia with shift to the left and toxic granulations. So I'd love to hear from Dr. Ilham how she will proceed with this case.
والسن العيان كان كام يا دكتور رانيا؟
7 years.
7 years child. على فكرة اللي ما قراش deeply وما عملش digging deep زي ما دكتورة رانيا بتقول when you find a morphological change dig deeper هيقرا الحالتين شبه بعض. ما هو دي بايسايتوبينيا ودي بايسايتوبينيا، ولكن dig deeper. know your patient first. الولد ده كان 7 سنين completely normal child وإذ فجأة he is ill appearing child with purpuric rash وanemic. وبالظبط وهاز history of vomiting and diarrhea. يعني الموضوع اللي دخله في هذا الموضوع preceding condition history of diarrhea and vomiting. طيب نفكر في ايه؟ اول حاجه تجيلنا عيان عنده بايسايتوبينيا اليوكوسايتوزس، عنده بصوا البريفرال فيلم عامل فيه ايه؟ في فراجمنتد سيل، في شيستوسايت، في بير سيلز. نفكر في ايه؟ الحاله دي اول حاجه تتحط لها مايكرو انجيوباتيك هيموليتيك انيميا. مها اول حاجه تتحط في الحاله دي. يبقى السي بي سي is a window for this disease. فاول حاجه عايزه كونفيرم ان العيان ده فعلا الانيميا دي اتس هيموليتيك ان نيتشر. فهطلب معلش further investigation يا دكتور رانيا. لازم هعمل further investigation عشان السي بي سي دي is a window. حط لي الماكرو انجيوباتيك هيموليتيك انيميا، فعايز اعمل reticulocytic count. I'm expecting the reticulocytic count will be high. الهابتوجلوبين، الاندايركت بيليروبين، هعمل ال LDH، ولازم هعمل الكدني فانكشن لان انا هختار ال HUS او الهيموليتيك يوريميك سندروم واحده من the top diseases بتاعه المايكرو انجيوباتيك هيموليتيك انيميا. ليه؟ لان كان في preceding history of diarrhea and vomiting. طيب اول ما تطلع الانفستيجيشن لو لقيت الكدني فانكشن امبيرد فعلا وفعلا الانيميا is hemolytic in nature، يعني الريتيكولوسايتوزس، consumed haptoglobin، high indirect bilirubin، ال LDH عالي with impaired kidney function, so the diagnosis is there. HUS is my diagnosis اللي هي hemolytic uremic syndrome. And from that بنemphasize مرة ثانية السي بي سي is a window to diagnose this disease. السي بي سي ما تتقريش lightly. السي بي سي عايزين نقرا فيها count ومورفولوجي after knowing our patient. لازم know our patient. Different history with different differential diagnosis. Different history with different differential diagnosis حتى لو السي بي سي ورت حاجات قريبه من بعض. يبقى know your patient and read the CBC deeply زي ما دكتوره رانيا ودكتوره سالي قالوا لنا النهارده because CBC is a window for different disease. Thank you.
Thank you so much, Dr. Ilham. And here I will give the mic to Dr. Sally to discuss with you another 2 cases. Thank you so much.
Now you have to see our next case. With this case, the patient was presented with the acute onset of fever, pallor, repeated infections, bruises, lymphadenopathy. And when we knew him, we just went for the CBC. This is the right thing to do. And we had this count that we can see. As you can see, the patient has high TLC. It's 43,000 and anemic, hemoglobin 8, and thrombocytopenia. Now we have the 3 lineages are affected. We have increase in count in the white BCs, the anemia, and the thrombocytopenia. When you see this case, the first thing that should trigger you, and whenever you see a white BC's abnormality, the one thing that you should never, ever go lightly with is the increase in the total leukocytic count of the patient. Because when you see an increased total leukocytic count of the patient, the next thing is you look at the morphology and you find any abnormalities in the morphological picture of the white blood cells in the form of anything that's called immature lymphocytes, blasts, monoblasts, paromyelocytes, anything that indicates an immature white blood cell, this is a very important trigger to show you that you should think seriously. Dr. Mahmoud, what should you think when you see this CBC?
هو actually يمكن الهيماتولوجيكال malignancies cannot hide يعني فاتحه نفسها يعني فمور اور ليس هي بتبقى تراي لينج فاحنا we can see في البيشنت ده ان عنده فعلا الوايت بلاد سيلز عاليه جدا البليتلتس بتاعته واطيه. First of all, I can ask for a simple investigation can be done in flow cytometry. الفلو cytometry في عيان زي ده is easy بعد differential count ومنه I can know if the patient is having plus. If this plus, I can differentiate what type of plus. So for this patient, I can do it on peripheral blood, or furtherly, I can arrange for a bone marrow to check the type by flow cytometry. Further analysis like cytogenetics or molecular, it takes some time to differentiate the type and risk stratification of different types of leukemias. But most importantly, not to miss في الأول خالص بالمورفولوجي زي ما اتقال. فالسي بي سي بالنسبة لي was a very good window إن أنا منه بمجرد ما شفته I should not miss. ساعات بنشوف عيانين جايين for screening بيبقى عيان من الأول السي بي سي كأن الدكتور ما تعاملش معاه خالص. بيشوف ليمفادينوباثي عند عيان فلاقي ان اتاخد منه lymph node biopsy despite in he doesn't need a lymph node biopsy وان بالسي بي سي لوحده ولو اتقرا المانيوال بتاعه واتعمل flow cytometry he can know exactly his patient within 24 hours. Thanks.
So whenever you see a lymphadenopathy, don't jump to biopsy before you open the window of the CBC. Our last case is a very good, healthy child complaining with just an abdominal mass that revealed to be a hepatosplenomegaly. When we did the CBC for him, we found also tri-lineage affection. We found leukocytosis, anemia, and thrombocytosis. The thrombocytosis is not marked, the anemia is not marked, but the TLC is high. So again, whenever you see a high TLC, please, 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 you have to look for the morphological abnormalities. We found that when we did the differential for this child, we found neutrophilia, basophilia, eosinophilia, and myelocytes. So what would you think about this patient, Dr. Mahmoud?
Okay, that's another good example of maybe هنا clinical in this patient في case زي دي في الميلوبروليفراتيف disorders العيان جاي بسبلين كبير. العيان most probably بيكون in a very good general condition. Most myeloproliferative disorders العيان بيكون in a good general condition. فالبيشنت ده عنده leukocytosis very high. I can think على طول of leukemia. Despite this, what type of leukemia? Is it an acute form or chronic form? الحاجات دي I cannot know except with proper investigations, except with proper history for the time to know when it started, and then for proper clinical examination. This patient is having splenomegaly and his white blood cells showed neutrophilia, basophilia, which denotes a chronic form of myeloid malignancy. So I will proceed for bone marrow aspiration, for cytogenetic analysis. For chronic myeloid leukemias, the cytogenetic analysis is crucial. I cannot start a treatment for such a patient without knowing the type of translocation that the patient is having. So it needs a specialized hospital to detect a translocation in chromosome 922. I can get a result within like 72 hours in a specialized hospital. And the patient is generally well and he doesn't have clinical symptoms and usually discovered by the organomegaly that the patient is having. So I can have the time to get my cytogenetics and then accordingly start my treatment. So really here, the CBC was a very good window to diagnose the patient, even by looking to it, having a patient with leukocytosis, with thrombocytosis, it always denotes a form of proliferative disorder.
To wrap up what we have said, the CBC is a good window. You have to know your patient very well. You have to take a good clinical examination, good history and physical examination. Please order the CBC before jumping into any invasive techniques. For the CBC, you have to look for the counts, the numerical values of the 3 lineages in the CBC, the RBCs, the white BCs, the platelets, and please, 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 the numbers don't add alone without the morphological abnormalities. Thank you very much. And thank Dr. Rania, Dr. Ilham, and Dr. Mahmoud.
Thank you, Dr. Ilham. Thank you.
Thank you. And no further investigation except after reading the CBC. No further investigation.
Yes. Congratulations for this valuable conference. Thank you for this fruitful session.